Hi, this is Dr. Sanjaya. Did you know that not all breast cancer patients receiving treatment are too ill to work or will lose their hair? My latest behind-the-curtain guest, Kerryn Ernst, speaks to me about the breast cancer myths and preconceptions that she has encountered as a McGrath breast cancer nurse. From the time of diagnosis and throughout treatment, Kerryn is there every step of the way to support patients and their families along the breast cancer journey. Let's jump into our chat. Hi everyone, it's Dr. Sanjaya here and welcome to our Behind the Curtain podcast. Today we have Kerryn Ernst with us. Kerryn is a metastatic breast cancer specialist nurse working at Canberra Health Services and the McGrath Foundation. And I'm sure we're going to hear a lot of interesting things from Kerryn today. So Kerryn, thank you for joining us.
Thank you.
Kerryn, when did you first get interested in nursing?
In year 11, so I knew I didn't want a desk job. So a lot of the options in Canberra were sort of to go into the public service or to go to uni. But just knew I always wanted to be a nurse and care for people, and just like the idea. I've always loved hospitals. Love the idea of hospitals. Just busy, always moving, people doing stuff.
And is that because there's a family connection or...?
Nope, I'm the first nurse in the family.
Oh, there you go.
Yep.
And you'll probably inspire others generations down to
My
do
son,
so?
yeah, I think my youngest son's looking at paramedicine. So that'll be nursing and paramedics degree. Yeah, he's very interested in it.
Right. And again, you mentioned it, that you grew up in Canberra, was it? So you're a Canberran?
From the age of 11, but yes, I will. I've only been thinking the last few years, yes, I'm a Canberran. So
excellent.
Been here most of my life now, married here, children born here, I'm Canberran.
And very happy with Canberra?
Love it. Yeah. Love it. Yep.
I think, surprisingly, of the people I've interviewed, many have come from other places, but are quite happy to settle down and call Canberra home.
Yeah, exactly. That's what I did. I left the big hospital, Royal North Shore.
Yep.
I worked there for a few years and overseas at St Vincent's Hospital in Dublin. So I did my time and, got all the career highlights out of the way and then came to Canberra, but then my career's just been great since I got here as well.
And of course, getting into nursing is one thing. It's like becoming an intern, and then you have to decide what you're going to do within that profession for the rest of your life.
Yep.
Was it a very easy connection to oncology and cancer, or was it fortuitous, or how did you
I think it's a combination. Canberra nursing always... it always held some sort of appeal. I don't know why, if it was that whole sort of private business. I mean, this is 25 years ago, cancer was, people didn't talk about it and you didn't see people with cancer as much as you do now. And then my first placement as a new graduate at Royal North Shore Hospital was in oncology, and very lucky to be on a ward where there were, 8 level 2 nurses, lots of new grads. North Shore used to take 100 new grads a month in the consortium, the new grad years. So very, very well supported. Paid to go and do your graduate certificate in oncology, so did that. And then my auntie was diagnosed with a very aggressive breast cancer over in Port Lincoln. Oh dear. Yep. And it was around the same time that I remember seeing Jane and Glenn McGrath on the TV when they turned the tomato sauce bottles pink. They did it as a fundraiser, one of their first things they did. Right. And I remember seeing that and thinking, oh, that's going to be great for my auntie. She had no support, had to travel to Adelaide for her treatments and things. Yeah. Lots of complications, wound breakdown, the whole lot. And I just remember thinking, I want to work for them. And here I am 15 years later. Wonderful.
And has most of that work been in Canberra, or has it...
Yeah. Since I've been with the McGrath Foundation, yes, it's been here with Canberra Health Services. So Professor Stuart Harris, who has since retired, had the vision to have a breast cancer nurse for patients with metastatic disease. Yep. So I was the first metastatic dedicated breast care nurse with the McGrath Foundation, and now they're up to about 30 nurses around the country now.
Oh, wonderful. And that's a name I actually remember very fondly, Professor Robin Stuart Harris. I've known him for a long time, and his dad actually did a lot of pivotal research into influenza back in the UK. So very nice guy.
Yes, he is very nice.
And now with this role, what sort of things do you do, Kerryn?
Yeah, so getting a cancer diagnosis is pretty shocking for a lot of people. Yeah. Getting told that your cancer has recurred or that it's metastatic in the first instance can be, I think in Dr. Kraft's words, catastrophic for a patient. It really is very confronting. So because despite the emergence of new treatments, better diagnostic tools and things like that, we still can't cure metastatic breast cancer. So my job is to try and help people understand their diagnosis. A lot of people have had cancer treatment in the past, and it might be 30 years, and now they've got a spot in their liver and they don't understand how that's related to their breast cancer from 30 years ago. So trying to educate people about that. Sometimes they have a lot of cancer and they've never been diagnosed with cancer before, and it's in lots of different sites. So trying to help people understand that would be the majority of my work. Coordinating treatments and appointments and blood tests and scans and everything is another part. Yeah. So a lot of liaison within the multidisciplinary team. And then, a lot of managing side effects and treatments and then, of course, advanced care planning. That's something I'm quite passionate about, that everyone should have their advanced care plan done. There's no certainties in life, so, yeah.
And look, with advanced care planning, obviously it's touching on a topic that people don't really think about and like to talk about. Yep. Do you find people are very receptive to that, or it can vary?
It can vary. I think I've recently done some work with the advanced care planning team, and we would go out to COTA at Hughes, Council of the Aged and Ageing, and people there were making appointments to come in. Perfectly healthy and well people were completing their advanced care plans, which was really good to see that people are proactive about it. But they're the healthy, well people at home. We've got sick people in hospital. And these patients, we don't know what their choices are, and we don't know who to contact, and we don't know, well, we do have contact details, but, the important people to have. So I think it's just really important to have done. And I think a lot of people are relieved when it is done. It's just something they don't have to think about anymore. It's done. Yeah.
And you've talked about the McGrath Foundation.
Yep.
So how do you balance that, or how does that connect with your Canberra Health Services role and what you do with them?
So the McGrath Foundation fund breast care nurses around the country, and so their aim is 250 nurses by 2025. I think we're close to that at the moment.
Fantastic.
So, and now they're looking at taking on all cancer nurses. So they're going to fund other tumour streams now, so moving into the lung cancer space and brain tumours and things like that, knowing that their cancer specialist nurses make a difference in the patient's cancer experience. So they give us professional development, a nurse portal, support, all that sort of thing. But basically, the day-to-day running of my job is through my manager here at Canberra Health Services.
So really, it does sound like the McGrath Foundation has been a game changer.
Yeah, it is. So it's good to know when you've got colleagues like, breast cancer is very common, and there are a lot of patients that come through our cancer service with breast cancer, but there's other cancers as well, and they don't get the same, they used to say it's the pink and the sort of the attractive cancer to have. Yeah. And there are other people that deserve as much support as breast cancer patients get. So they're moving into that field now. Okay.
Yeah. And cancer, of course, has changed recently. Everyone knows chemotherapy. Yeah. But a few years ago, this phenomenon called immunotherapy appeared, and it's just changed the whole cancer landscape. Yeah. I imagine in order to communicate effectively with your clients and your patients, you have to keep on top of all this.
Yeah, we do. So the immunotherapy, it has made an appearance in the triple negative breast cancers, but very, very much used in melanoma and lung cancers. And I know that from my colleagues that I sit, there's 20 of us, and we all sit near each other, so you overhear things. Yeah. But close relationships with the drug reps, because they're the ones that keep us up to date. They're the ones that tell us, the side effects, what to look out for, managing the toxicities. And of course, we're the point of contact for the patient. So we're the ones that they ring when they say, I've got this going on and I need some help. So, and try and keep them out of hospital. That's our aim.
And you touched on it now, with breast cancer, immunotherapy not a huge role at the moment?
No, more in the triple negative space. So everyone's, and this is something...
I'll just explain that what a triple negative means.
So everyone's breast cancer is a different experience. So you can have two people sitting side by side in the waiting room, and they're going to be offered different treatments and different things based on their type of breast cancer. So basically there's 3 receptors that we look at: the HER2, the estrogen and the progesterone. Yep. You can have positive of all 3, you can have negative of all 3, you can have a combination of any of them, and that all comes down to your histopathology, what they take when you have your surgery, if you have surgery or if they've taken a biopsy, because not everyone has breast cancer surgery, not everyone gets chemotherapy, not everyone needs radiation. It's all very different.
Yeah, that's true. The journey is very different, isn't it? There are a whole lot of myths and preconceptions. I think you also touched on one then when you're saying you're listening to your colleagues who are specialist nurses in other forms of cancer. Yeah. Because I often have people come up to me and go, but cancer's cancer. I actually say, well, actually it's not. They do have some commonalities, but a melanoma versus a lung cancer versus a breast cancer versus a sarcoma, they're quite different in how they behave and how they're treated. Yeah. What sort of myths and preconceptions around cancer, breast cancer, have you encountered?
They're not giving me chemotherapy because it's advanced. So that they're not giving me treatment because my cancer is metastatic. That's not true. Or they're just giving me the tablet because, I'm expected to die. Well, that's first line treatment in that type of breast cancer. So, so I guess, just because your neighbour got chemotherapy and you're not doesn't mean that we've given up on you. It doesn't mean that you're not going to get it at some point. Yep. It just means that this is the right treatment for you now. And it's international, the treatments for breast cancer. They follow lines of treatment. So the treatment you get in Canberra would be the same if you went to Sydney. A lot of people spend a lot of time looking for second opinions, going into state, and it's pretty standard how we use the treatments. So, and we contribute to the CASP trials and things here as well. So you can get everything in Canberra that you need to get, I think.
No, I think that is really important. You're right. We do see people not just with cancer, with other conditions, thinking, maybe I'm better off seeing the big professor in Sydney or Melbourne. But generally, the standard of care for most conditions, including cancer, is standard.
Yeah, it is.
Wherever you do it.
Yeah.
And any other...
Oh, the nausea is a big one. So, I'm not having chemotherapy because I'm going to spend the next, 6 months vomiting. The supportive medications that we give now, the anti-nauseas, the other drugs that we use to manage nausea have changed so much now. So most people manage to work full-time or, work at least. They might take a day off for treatment. They might take the day off after treatment because it's been a long day. They've been busy. But most people work and manage their cancer treatment very well.
Yeah, look, and I think that is a misconception that a lot of us, even within the healthcare profession, would have. We'd think, you're having chemotherapy. Well, you better take some time off and lie in bed or lie on the couch in front of the TV because you won't be able to do anything. But that's not true. Although
Catherine, Princess Wales, she can't be having chemotherapy. She hasn't lost her hair. Well, there are agents that we give where you don't lose your hair. So, I should be talking about the royals, but she has had treatment for cancer and you don't have to lose your hair. So that's a misconception as well. You won't look sick. You don't have to look sick.
Yeah, so it doesn't have to be a horrendous journey.
Exactly.
Potentially. And in terms of coolest things you've done, what would you suggest? I mean, I know you've done some fellowships and being clinical lead for certain projects. Yeah. What sort of things jump out of your long career?
Probably the Churchill Fellowship was pretty cool. I had to interview for that, do an application, and then you're lucky if you get to interview. It's quite a prestigious award. But the interview over at the ANU, I honestly felt like I was being interviewed by the village people. There was like a fireman, a policeman. It was quite funny. So I just kept waiting for them to break into the YMCA. And then to get that letter under embargo that you've been chosen for a Churchill scholarship is quite thrilling, actually. And then, they paid for me to travel to the US and Canada to look at different cancer centres. Okay. And so that's helped shape, our model of care and how we, do things over there.
And although we talked about treatment within Australia, major centres all being the same, did you find many differences when you went to the US and Canada? Yeah, so the access to healthcare was a big thing. I remember sitting outside the Princess Margaret Cancer Centre in Toronto and a lady came out just to eat her lunch in the sunshine and we just got talking, as you do, Australian overseas, you start talking to everybody. And she'd had treatment for breast cancer. She was flying from India to Canada for her treatment. This is just something that she was doing. I think she had family in Canada as well. Right. But she didn't have a lymphedema garment. She hadn't seen a breast care nurse. She didn't know any of the things that we do here that we do really well. So I think the McGrath Foundation putting
nurses. I mean, yeah, like I said, we've got nearly 250 nurses across the country, and a lot of them in remote and regional areas as well. So just that point of contact for people, because they don't have that, and that's a very easy service to give people. Just that information, like, can I travel? What should I be doing when I travel? So, yeah.
And that's also interesting, because when we talk about things being different in the US and Canada, you think, rich countries, they're, rich, highly developed countries, even more so than Australia, they'll be better than us, but not necessarily.
Always better, no. They have a lot of people doing a lot of jobs, but they've got one person that's dedicated to booking that thing, whereas we have a team of people that might not focus on that one thing. It just comes up in the job. So it's very, but they're also very, that's not my job. Whereas we sort of go, I'll talk to your doctor about that and I'll help you with that. So we probably, not outside scope or anything like that, but we're probably more encompassing of other things that can impact someone with cancer, rather than they just do that bit there. That's what they'll focus on in their job. So I found that quite difficult.
So it's more holistic
here. Yeah, I think so, and more collaborative with the multidisciplinary team. Like the breast cancer multidisciplinary team has been up and running for about 25 years. Yeah. And they still have some good discussions about patients.
And look, tell me who would be in that multidisciplinary
we've got medical oncologists, radiation oncologists, their registrars, surgeons, so breast surgeons, pathology are there, radiology are there, genetics attend, breast care nurses attend. I'm probably forgetting someone very important, but that's about it. And they get together and they have really robust discussions about what's best for that patient for treatment.
Yeah, look, and certainly, again, going to my field as well, when you have heart infections, what we call endocarditis, there's good studies out there showing that if you have a multidisciplinary team with a heart surgeon, a cardiologist, and an infectious diseases physician, you have better outcomes. So I think, look, it's a very simplistic level, you get the relevant people in a room together talking, things happen. Like
exactly.
The corridor consult.
Yes, things happen.
And now, how long have you been in this role for?
Well, I've been a cancer specialist nurse for 16 years. I've been the metastatic breast cancer specialist nurse for 15 years.
And look, in that 15 years in Canberra, what sort of changes have you seen?
Ooh, well, I think the biggest thing is the treatment changes. So the new CDK4/6s, they're a new tablet given with endocrine therapy. Some of the new, like I said, the few triple-negative breast cancers, like the immunotherapies for those. I mean, we've always had the multidisciplinary team, so that's a constant. I think my team has grown. When I started, there was probably 5 positions. We're up to 20 cancer specialist nurses now, which just goes to show the growth of the hospital and cancer services. And we all have our little area of specialty. So what else has changed? The new hospital. Yeah.
Oh, of course, that's right. And within the metastatic breast space, are you the only specialist nurse, or do you have others working in the space with you now?
No, there's 2 breast cancer specialist nurses for early breast cancer, and then just me for the metastatic.
Okay. So that really is going down into fine detail, isn't it? Early versus specialist. Is it something you could sort of switch to? You could switch between those positions, or is it quite different?
They can be quite different. So, I mean, the treatments are changing now for early breast cancer. So they're using some of the drugs that I've used in the metastatic setting, they're using for longer term treatment for early patients to try and, reduce the risk of recurrence. So they're using those drugs that I've already been using for years. So that's probably one of the, but it's very different. So my patients, a lot of them say, well, the difference is that they know the number of the bus that's going to hit them. So, they sort of, a lot of patients with early breast cancer, I think I could say they live in a fear of recurrence, and that's a very known thing. And it's, living with uncertain prognosis and stuff is very difficult as well. But I think my patients, they know that they've got, they just know that that's it now, but we don't have an infinite number of treatments. So it's more of a marathon, not a sprint. We try to taper doses, get things right, keep them on a treatment for as long as we can. So just managing side effects and keeping them on that treatment, because when I started, the prognosis, everybody was sort of seen and treated and were deceased within 3 years.
But now it's a whole different ballgame.
Now I've got patients that I've been looking after for 10 years.
Yeah.
So it's, it's improved a lot. It has.
And that was my next question. When do you say goodbye or end that professional relationship with a patient who's in remission? Or do you continue that because it could potentially always come back?
I have a few patients. I mean, there's been whispers of remission in the metastatic breast cancer space. Most people will be on a treatment. There's a few, only a handful of people that have been on treatment for many, many, many years and are having a treatment holiday. But I guess we would think at some point it's going to come back. But yeah, it's mostly just I'm always available. The referral's always open for people to see me if they need to or contact me.
Yeah. And so how many people would you now have under your care?
Well, thinking that I only see people that come to Canberra Health Services, about 120 at the moment.
About 120.
Yeah.
Well, that will keep you busy, Kerryn.
Keeps me out of some trouble.
Look, you touched on another issue where in the ACT we're surrounded by New South Wales. We have intimate relationships with those surrounding areas because a lot of people work in Canberra and use the health facilities. Do metastatic breast cancer patients in surrounding New South Wales use our services? Or
Absolutely. So yes, because we're the nearest public cancer centre, then yes, they do a lot from Queanbeyan and Sutton and Gundaroo and everywhere. And always here to support them. But the model of care for the McGrath Foundation is that patients should be supported by the nurse sort of closest to their postcode. So there is a McGrath breast care nurse who does all cancers. So that's the thing. If there's not a metastatic McGrath breast care nurse in a health centre, the early breast cancer nurses will look after metastatic patients as well. So we've got Belinda, she's on maternity leave, but Jen's covering her out in Queanbeyan, and she looks after all the patients from that area. So we would sort of share care. Like if I know that they've come in and this has happened, we just let Belle know or let Jen know. So it's sort of but they can reach out to her because a lot of people just have questions about, what next? What do I have to do? What does this mean? All those sort of questions, and any breast care nurse can answer them.
Oh, no, sure. Yep. And I guess the future, what do you think the future holds the next 10 years? Are we going to need more specialist metastatic breast cancer nurses? Are we going to see a burgeoning of cancer? Or what do you think, what do you see the future?
I think we're going to see patients living longer, hopefully better on treatments. So getting more bang for their buck out of each treatment, I guess. Not having these. Well, I'd like to see some improvement in the triple negative breast cancer space because that's still quite a poor prognosis. It's a very aggressive type of cancer.
If you were starting out in nursing and you're listening to this podcast and thinking, what Kerryn's doing is amazing, what sort of pathway would you suggest they follow?
I think you need to say yes to... So find an area that you love, first of all. So everyone has their chosen field. Do that. Do the hard yards, do the ward work, do the night shifts, do it all because you're talking to patients and you're getting experience and that counts for more than you'll ever know. Say yes to new opportunities. Do your study, do some postgraduate study because that's still... You get more cred if you sort of done the study and done the time as well. So, and then just keep learning, I think is the thing I've learned. So I've done 2 master's degrees and a couple of grad certs, and I think it's, and I'm, always looking at doing something else. So just keep learning and keep interested in stuff and always just think of the patients first.
Okay, excellent. And Canberra as a place to work in? Oh,
awesome. We do have a bit of traffic, so this whole no traffic thing, there is a bit of traffic, but it's usually for about half an hour and it's gone. So,
look, you're right. 20 years ago there wasn't any, but now there's a little bit depending on where you live.
Exactly. So. Well, I come from the other side of town, so it's not too bad, really. It keeps moving anyway. You're not stuck in traffic. It's just there's more on the road than you used to.
For our 6 million viewers, 6 million listeners in Melbourne and Sydney, just to let you know that it's not traffic. It's not real traffic.
It's nothing like what the other cities have. No, but it's a great place to live. the opportunities, even just going to the open days for ADFA and UC and everywhere like that, there's really good opportunities for, I've got two sons, so there's 5 universities to choose from in Canberra. Yeah. So it's easy living, it's lovely. Canberrans are good people.
Look, on that wonderful note, talking about Canberra, and after telling us about your amazing career and the wonderful job that you do, I would like to thank Kerryn Ernst for her time today on the Behind the Curtain podcast.
Thank you. Thank you for having me.
Anytime. Thank you for listening. I hope you'll join us behind the curtain for our next episode, where we'll delve into the story of another of our fantastic health professionals here at Canberra Health Services. If you're interested in starting an exciting career with us, head to our website to join Team CHS. And that website is www.canberrahealthservices.act.gov.au/careers, CAREERS. I acknowledge the Ngunnawal people as traditional custodians of the ACT, the land I'm recording on, and recognise any other people or families with connection to the lands of the ACT and region.